structural interventions, including aortic and mitral valve today, as well as some great talks. Our first talk is an update on structural heart disease interventions by Dr. Charanjit Rihal. He needs no introduction. He's extremely well known to our cardiology and interventional cardiology community. Dr. Rihal is an academic interventional cardiologist at Mayo Clinic, and he's been the principal investigator on multiple grants and multi-center research trials. He's been funded by the National Heart, Lung, and Blood Institute, by Mayo Clinic, and has been widely published in premier journals of our community. He's chair of the Division of Cardiovascular Diseases. He's had multiple awards, including Teacher of the Year, Professor William S. and Ann Atherton Professor of Cardiology, and has been elected top doctor by his peers on multiple occasions. So I'm going to hand it over to Dr. Rihal without further ado. Dr. Rihal, over to you. Dr. Rihal, we can't hear you. If you could, I think your mic is muted.
We can hear you, Chat.
You can hear now? Test 1, 2, 3.
Yes, we can hear you, Dr. Rihal. Over to you.
Okay, very good, very good. Well, one more time, I'd like to thank the organizers for the kind invitation to present at this year's Pakistan Live. I've been enjoying watching the challenging case from AFIC, and I see that you struggle with the same challenges that we do here with elderly, very sick patients. But the exciting thing about structural heart disease is that we have developed so many new therapies in recent years that have allowed us to help a greater and greater population of patients. So what I have been charged to do in the next few minutes is to give a broad overview of the area that I work in, which is structural heart disease. And I hope I can transmit some of the excitement around the innovation in this field and the challenges. So I'm going to start with sharing my screen. Can you see my slides okay? Are they coming through?
Not yet, Dr. Rihal.
Okay, one second.
Yes, we can see your slides now.
I'm screen sharing now. They should be coming.
Yes, we can see them, Dr. Rihal.
Okay, very good. So this is the title of my presentation, Innovations in Structural Heart Interventions. And this has been a very, very exciting field to work in over the last 15 or 20 years. And, I know there's a lot of expertise already in Pakistan. They're doing very challenging TAVR cases. So I'm not going to belabor TAVR, but I'm just going to talk about 2 or 3 points that I would like to make. The first is, this is the very first TAVR case that I personally was involved in. And I remember it distinctly because the 55 millimeter gradient virtually disappeared on the table.
Down a bit, yeah.
And you can see the gradient just melted away. And it was like a near miracle after many years of doing balloon aortic valvuloplasty, which was a struggle. The first time we put this aortic valve and we saw the gradient disappear, we realized this was a game changer and truly a transformative innovation. And now, of course, this has become the preferred method for aortic valve replacement in America and around the world. I want to just point out a little bit of the history of TAVR. This is Dr. Henning Ruud Andersen. He actually is a Danish cardiologist who first conceived of this idea while he was a trainee. And in 1989, he did the first animal studies, as you can see in the swine model. 1989, he did the first animal studies. And it was almost 20 years later that this was actually approved. And this is, of course, the famous photograph of Dr. Alain Cribier from France, and the first patient that had an aortic valve put in percutaneously. The gentleman did fine postoperatively and really revolutionized this field. So it took 20 years from concept to human application, and then another 10, 15 years to grow to where we are today. Now, the second point I'd like to make about TAVR is it is incredibly effective. I am not going to go through much data this morning. Rather, I'm going to concentrate on giving a high-level overview, but suffice it to say that in the original partner trial, we observed that the TAVR procedure could save up to 200 lives per 1,000 patients treated. And in comparison, you can see that aspirin for myocardial infarction would save 24 lives per 1,000 patients treated, and reperfusion with thrombolysis would save another incremental 24 or 25. So TAVR is one of the most effective and highly efficacious treatments we have in all of cardiology, save perhaps heart transplantation. And the TAVR valves have continued to evolve. This is the Edwards series of valves from the original Crivier-Edwards design on the left to the SAPIEN 3, which we are currently using in America. And of course, Medtronic has had a whole series of self-expanding prostheses as well, with excellent randomized controlled data supporting their use. So these are the two main valves that are being used in America now and around the world. And as more and more clinical trials come out, the indications have expanded for TAVR, such that we are now using TAVR across the spectrum of risk for calcific aortic stenosis for low risk, intermediate risk, and high risk patients. Where there remains controversy are heavily calcified valves, bicuspid aortic valves, asymmetric nodular calcification, and access, alternative access, is a major issue. And I note that on your program, you will have a transcaval TAVR procedure presented later this morning, which is very exciting. So TAVR is now an established procedure that is done in, I believe, approximately 700 centers in the United States. And we went from doing 1 or 2 a week to now doing 2 or 3 a day in our cath lab. And it's really a tremendous procedure. The next one I'm going to just illustrate, and I don't know if this is being done yet in Pakistan, but this is the mitral clip procedure. So this is a cartoon model of how the mitral clip procedures perform. You can see we're entering the left atrium. This is looking from above from the surgeon's view. Transeptally, we put in a 20 French guiding catheter, and through that, the mitral clip can be extruded. Now, this clip, it can be rotated, it can be translated and moved back and forth such that we can find and navigate to precisely where the regurgitant jet is coming from. Now here you can see how we grasp the leaflets. There are actually these tiny little teeth on the grippers that hold the leaflet, and then the clip closes such that we can reduce the regurgitation from severe down to mild or trivial in almost all cases. We typically can't eliminate it, but we can get it down to where it no longer presents a clinical problem. Now, this is a live 2D TEE showing how we're pulling the clip back from the left ventricle, straddling and cradling the mitral valve leaflets posteriors on the left, anteriors to the right. And then what you'll see is the grippers there. Did you see that? The grippers came down. They're going to hold a leaflet, and then we're going to close the clip, creating a nice tissue bridge. And here the clip is being closed, and we get a beautiful reduction this way. In structural interventions, the advent of real-time, three-dimensional transesophageal imaging has been truly revolutionary. You can see how we can quickly tell that we're at A2P2, we're not too lateral, we're not too medial. And in the bottom right image, we can tell very quickly that we have created a nice bridge with a double orifice. And this is the anatomic result that we aim for. Now I would like to show you the physiologic result that we aim for. At baseline, this patient had a blood pressure of 90/50, and the V wave in the left atrium was 42 millimeters of mercury. Following clip implantation, you'll notice that the systolic blood pressure immediately jumped up to 150. This is a very, very good sign, and indicative of the fact that now we have doubled the forward cardiac output. And the left atrial V wave fell to 11 millimeters of mercury. So a patient that has such good physiologic results on the table, this type of patient will improve immediately, and they will often note, even the same day, that their breathing is better, and by next day they're walking much, much better. Here's another patient with an elderly woman with heart failure, severe pulmonary hypertension, and mitral regurgitation. You can see that putting the clip on the upper right image greatly reduced the degree of regurgitation. Now look at this. These are the acute V waves in somebody with acute mitral regurgitation, 60 millimeters of mercury. And with clipping, they go down to 20, or actually less than 20, again, indicative of an excellent anatomic and physiologic result. And indeed, this particular patient, the chest x-ray, 30 days later, you could see the heart size actually shrink. And the clips are clearly visible on the plain chest x-ray. So now in the United States, this is a fully approved therapy. We again do this almost on a daily basis. We can now treat a wide variety of pathology, both functional and various types of degenerative mitral regurgitation lend themselves to clipping as potentially a first treatment option for mitral regurgitation patients. In younger, good risk surgical patients, we still prefer surgery, particularly robotic mitral valve repair, as we believe we can attain the best results with no regurgitation and the best long-term results. But for most of our elderly patients, we are now favoring mitral clip as the first anatomic treatment. Now, what about paravalvular regurgitation? This is a problem I've been involved with almost 20 years now. And it's a fairly common problem, actually, because it's underdiagnosed and underestimated. But probably, 5 to 17% of all surgical valves that are put in will have some degree of PVL. And it can present with hemolysis and or heart failure and be very difficult to treat. It can affect any type of prosthetic valve in any position in the heart. And so if this is a 3D exam, you can see this patient has had a mitral valve repair with a ring. And now there's literally a defect, a hole beside the ring. What we're going to do is we're going to place a catheter. This was probably a 6 French coronary guiding catheter, placed antegrade from the left atrium into the left ventricle. And then through that, we can place any one of a variety of plugs. The ones we favor are the thin nitinol braid ABP2 devices, as we feel they provide an excellent result with almost no risk of hemolysis, as opposed to the thicker braid devices like PDA occluders or muscular VSD occluders, et cetera, which are associated with an almost 20% increase of accelerated hemolysis. So we tend to avoid those. Analogous techniques can be used for aortic PVL, where we go retrograde around the aorta, cannulate the defect, traverse the defect with a delivery system, again, typically a coronary guiding catheter, and then we can place any one of a variety of plugs. So here you can see around this prosthetic valve, we have now placed an ABP2 device. This looks like a 10 millimeter device. In addition, there's a mechanical mitral valve prosthesis. So the operators have to be extremely careful that any plugs we place do not interfere with the normal motion of the mechanical heart valve leaflets of the surgical prostheses. Our goal is to get as good a reduction as possible on the table. The better the reduction that we get on the table, the better the acute and the long-term results will be. So we really try to get down to 0 or just trivial regurgitation, stacking in 2 or 3 devices if necessary. Using these techniques, and we've now done a few hundred of these, we feel that we can offer patients now a 90% uncomplicated success rate for percutaneous mitral and aortic paravalvular leak closure. So at our center, this tends to be preferred as the first line treatment option. If it works, which it does 90% of the time, that's terrific. If it doesn't, then we refer the patients for surgery, which typically is associated with significant risk in this population. Now, I'm going to shift gears, and you'll see how we translate techniques from one anatomic problem to another. This is a 77-year-old woman with a Hancock tube bioprosthesis that was placed approximately 15 years prior to her presentation. You can see there's only one leaflet that's moving. The other two leaflets are thickened and frozen, and there's a high gradient, almost 20 millimeters across this Hancock mitral bioprosthesis. So we have developed, and now others have developed and are utilizing techniques for antegrade transvenous transseptal implantation of prosthetic heart valves into mitral bioprostheses. This is a very nice procedure that can be done quickly, safely, and efficiently with patients leaving home typically the next morning. And you can see how we do this. We have to take care to mount the TAVR valve the other way for antegrade blood flow to occur. So this illustrates how we do that. The inflow is on the left and the outflow is on the right when we're treating mitral valves, of course.
Chet, we have 1 minute left. Sorry to interrupt.
Okay, no problem. This is the final result. And I think if there's only 1 minute left, let me do this. Let me just show you a couple of mitral valve systems. This is the Caisson system, which unfortunately is no longer available on our market, but we are now using the Edwards Sapien 3 system at our center, which consists of a dock that we place percutaneously, and then within the dock, we can place a modified TAVR valve, allowing for complete percutaneous mitral valve replacement. So tricuspid valve is very challenging to work on. And currently we are doing various edge-to-edge techniques like with MitraClip or with the Pascal spacer device, which is another investigational device for the tricuspid valve. But over the next 1 or 2 years, many new devices will be coming available for clinical investigation. So I think this probably will wrap up, and I'm glad that we have a few minutes for questions and answers, and I would be happy to take them. So here are the acknowledgments. To do this work, especially innovative work, requires a comprehensive team approach from interventional, surgical, and imaging experts, and my acknowledgments to all of them. So thank you for listening. I'm happy to engage in discussion now.
Thank you, Dr. Rihal, for a wonderful overview of some exciting advances in the structural valve space. Let me open it up to our chairpersons and panelists and see if they have any comments or questions.
Hi, thank you so much for such a wonderful presentation. My name is Ali Raza. I just wanted to ask you a quick question regarding because in Pakistan we have got a low volume for these probably procedures being happening. Do you guys have any volume which you guys have put up to the operator to keep up their competencies for structural heart procedures, or is there any number which you could define for that?
You know, unfortunately, there are no clear guidelines or numbers. It's very difficult to define numbers like that. We did determine, doing our own research, that it takes about 30 cases of TAVR to really become proficient at TAVR. And I would think that's a minimal number for training. And then to maintain procedural competency, I would think at least that number per year. Now, what will happen, I predict, is as you launch these programs in Pakistan and other parts of the world, once people realize how good the results are, then the programs will develop rapidly. The other thing I think that needs to happen, particularly in South Asia, I think we need our own indigenous valves being developed, because these technologies are very expensive, as you all well know, and we need our own technology that can be applied to much broader segments of the population.
So in Pakistan, we have a significant bicuspid valve population, and I'm going to get your thoughts on where TAVR is in the bicuspid patient population, especially type 0 bicuspid. And then I'd like Dr. Tahir Saghir, who's here and has significant experience in treating these patients in Pakistan, to comment as well after your comment.
Sure, thank you. Well, I'm sure he has much more experience than I do. Most of the bicuspid aortic stenoses that I see or that we see in the adult side, we see them very late. So by the time we get them, the valves are heavily calcified. And if they have a 10 or 15 millimeter nodule on one of the leaflets, highly asymmetric calcification, I don't favor TAVR as the first line option unless they're high risk for surgery. Because I do believe the surgery for this condition, many of these patients are in their 50s and 60s, is low risk and the results are very predictable, whereas the results with TAVR are less predictable. So we need more data. And right now, our decision is based on the individual patient's pattern of calcification and anatomy. I'd like to hear what you're doing there.
Can I, Usman, can I ask a question?
Can we have Dr. Tahir comment and then I'll come over to you.
Thank you. We are doing, definitely we have more incidence of bicuspid aortic valve in our region and also in China. As you know, these patients of little bit of younger age group as that of the classical patients for the TAVI for tricuspid valve. Along with these asymmetry of the cusps and the aortopathy, definitely as you suggested, but for the last 3 or 4 or 5 years, we are doing these patients, but we don't see any more incidence of PVL or any increased incidence of PPM implants. And definitely we use the strict criteria that is being developed for the tricuspid aortic valve. There is no individualized so far any criteria, but we have very much help recently with the development of this cusp overlap technique that helps us a lot.
Yes.
Dr. Shabazz?
An excellent presentation. There are a couple of questions which probably I would like to have clarifications about. When you're selecting the different kind of valves for a patient for TAVI, what are the criteria that you have, for example, regards the takeoff of the aorta, horizontal, or the angle is much less there? That's number one. And number two is that if you have calcification only on one cusp, and the other cusp is free of calcification, does that also hamper your TAVI procedure? And for example, in such a case where there's a bicuspid valve, what would be your approach?
Yeah, so thank you for your question. So my general advice is for each center to pick and master one type of valve. So for example, at our center, we use the balloon expandable valve, probably 80 or 90% of our cases. And we are confident that we can get it in to our patients almost always, including using alternate access of various types if we need to. So each of these valves, the self-expanding valve and the balloon expandable valves, have a significant learning curve at first. There are many tips and tricks that are necessary to get them in there. But we tend to favor the balloon expandable valve because of the ease of deployment, the lower PVL rate, and the lower pacemaker rate. There are some circumstances, however, where we may favor a self-expanding valve, such as aortic valve and valve implantation for bioprosthetic aortic stenosis. With regards to your second question, for the asymmetric calcification, it's highly individualized. What one has to do is to make a judgment as to what the risk of a catastrophic complication like acute coronary occlusion or annular rupture is. I always worry when we have such marked asymmetric calcification of one leaflet, one cusp, or the LVOT, that the risk of annular rupture it could be elevated. So that can be a catastrophic complication, as you know. Then the second complication that I mentioned is acute coronary occlusion. That can be anticipated, and we can take measures to protect the left coronary if necessary. So I hope I answered your questions.
Thank you. Over to Dr. Bashir, you have a question.
Yeah, Chet, this is Bashir Hanif. First of all, thank you very much for sparing the time. I know you have been extremely busy and you're on call right now even. Just one quick question. Like, what do you think that just like TAVI, like valve for aortic regurgitation or mitral regurgitation, you think kind of will be routine? How long you think it will take to get to that level?
Yeah, so this is a great question. So the mitral valve is much more complex than the aortic valve. So I think it's going to take some years. And it's all the valves that I have used and seen being used are much more challenging to get in than a TAVI valve is. The TAVI valves typically are quite straightforward for most cases, not all, but the transcutaneous mitral valve replacements, almost every case is a challenging case. So it's going to take some time. However, having said that, the pace of innovation is accelerating, and I'm convinced that innovations will come over the next 5 years that will allow us to offer this to our patients. But it's going to take time.
Thank you. Yes, exciting times indeed. I have a question. We have Bilal Murad online, and I wanted to get Bilal's thoughts on. So, as these devices get better and better, at least in the aortic valve space, there's a lot of downward creep in terms of the age cutoff. We're doing younger and younger patients, and the heart team discussions are more and more about planning for the next valve rather than just the first valve. So what are some of the considerations you take into account when you have a relatively younger patient who is going to get TAVR, and you think about what they're going to need in about 10 years' time?
Thanks, Chad. So I think a couple of things. One is we have to look at the patient's expected lifespan. They have comorbidities. Sometimes even patients who are younger. At least in the United States, we expect patients to live up to about 90 years. So if you have a 60-year-old, you have to plan for the next 30 years. Will they actually make it over there statistically based on their comorbidities? The second issue is the longevity of the valve itself. And then, of course, you look at the aortic root anatomy. How hostile is it? What is the likelihood that we're going to get a really good result? I look at the size of the valve. If a person who's young is going to get a very small valve, and there's a potential for root enlargement, I would much rather the person go for surgery, and then potentially surgeons can sometimes put in a slightly bigger valve, root enlargement. Look at the hostility of the aortic root complex, how much of calcification there is. If there's a bulky, protuberant, excessive calcium, even though you can technically get a good valve over there, you may not get it may not be as safe as surgical intervention. But I think ultimately the question really will come down to longevity. Right now, the next generation valve from Edwards is going to be the same valve as the Inspiris Resilia valve. And so really we have reason to believe that if you think you're going to do an operation and that is expected to last for about 15 years or so, it's not unreasonable to expect that a TAVR valve hopefully will last that long at least. Maybe even a little bit more perhaps if they have a better hemodynamic profile. And then what we don't know, of course, is what is the outcome of valve and valve in the long term. TAVR and TAVR valve. We don't know exactly how long the TAVR and STAVR will last as well. So those are all questions that are emerging, but I suspect that as the technology gets better and better and we have more evidence of longevity, that this technology will be applicable in younger and younger patient populations. So hopefully that answers the question.
Thank you, absolutely. So I'd like to thank Dr. Rihal again for taking time out from his busy day and a wonderful, wonderful overview of where we are in the structural space. I think we're going to move on to our live case over at AFIC. We have Dr. Omer Goktekin, Dr. Asad Akbar, and Dr. Hameed Siddiqi there, as well as I believe Dr. Sohail Aziz and Dr. Mohsin Saif. So over to you. Can you guys hear us? And please let us know where you are in the procedure and the patient details. Dr. Asad, can you hear us? Can you unmute your mic? We can't hear you. We still can't hear you.
All right. Hello, can you hear us?
Yes, yes, perfect. We can hear you now.
Yes. Okay, perfect. So I'll get, hello and good morning from AFIC here. We have a pretty exciting case, but I'm going to introduce our team here. So on our left is Professor Omer Goktekin, and Adnan is accompanying him. And then we have Brigadier Siddiqi, Brigadier Asif, and we have Ali who's helping us. And then on anesthesia, we have Dr. Rehan. So we'll show you where we are at this point. Just go through the first few. Let's get the history down. So can we have the slide?
We can see the gradient, it's quite impressive.
Yeah, it is. This was a slide for the slide basically. So this is our,
Yes, we can hear you. No, the slide just went away. Here, we can see it now. We can see it now. Do you always have a safety wire for your cases or down the? And what's your choice of wire for that? And your patient is conscious sedation or?
So that's a very good question. So the plan up till this morning was conscious sedation, but the patient was very anxious this morning.
Do you always use the, sorry, it's Ali Raza here. Do you always use the pacing wire? Because I tend to mostly prefer over the wire pacing, but is it just because it's a live case, or do you? Sure. Sure.
While you're doing that, we have Dr. Wasif Qureshi, and I'd like to get his thoughts on the size selection for the valve. The cornea heights are pretty good. The perimeter is somewhere between a 29 and 34 valve. Would you prefer 29, 34? Dr. Wasif, what are your thoughts on that? And Asad, what are your thoughts on balloon valvuloplasty? Are you doing it for all cases? Are you doing it based on some criteria? So there they have the balloon across the valve, and I think they're getting ready for BAV.
So have you or anyone using the LV wire for pacing instead of putting a pacemaker routinely?
So
I have, and I think the cases where I do it is no baseline conduction system disease, where I'm fairly confident that the valve won't be a deep implant, because as you know, with Evolut, there's a higher chance of pacemaker, and so if they go into heart block, then you're dependent on your LV wire for pacing them. Versus, so I think if they have a right bundle already, if you're thinking that it's going to be a deeper implant, I usually put in a temporary wire.
Yeah.
Bilal, have you been or Wasif using single side stick, one superiorly and one inferiorly instead of going bilaterally?
I have completely changed our program. So we used to be dual arterial access, but I think what COVID did is it forced us to rethink our program given a situation of availability and staffing. And so we've actually moved to a same-day discharge protocol in selected patients. And I was thinking about seeing our design. I actually eliminated the temporary pacemaker and exclusively through the LV wire now. I understand what I found that to be a very, very efficient way of pacing, and it takes away the slightly additional risk of chronic perforation and pacemaker as well. Yeah, I have exclusively moved to a single access site right now. It's also not reduced vascular complications.
So what do? You put one in SFA below down, and what kind of wire do you leave in there, or what we have done in few cases is that put in very small sheath or even introducer down in SFA, and through that maybe leave 018 wire just for safety and complete the procedure, and then check it, make sure if you need, then you can go from below. What is your protocol?
And we have a venous line and we get anesthesia for drug administration. So I have a single arterial access, which is just for the TAVI sheet itself. And I'm almost exposed to the sapien type here, so generally speaking, it's there between 14 and 16.
So,
One arterial in the groin and one arterial in the wrist.
so you can take the picture from the right radial as well, and there are balloons which is known as an armada balloon, which you can use also to get from the radial down to the leg if you get any complications. So if you have, although in Pakistan we don't have armada balloons, but a single femoral artery and a left radial artery is usually good enough for us as well in Peshawar. And we use always the over the wire pacing. We put a femoral vein, just a wire in the left femoral vein, just to leave it there in case if we need an access and an urgent temporary pacemaker. Otherwise, we use our own confida or wire for the over the wire pacing.
Hello, it's Asad from Peshawar.
So they have the valve.
What about the state of
across.
Sentinel devices? Have you used it, and what are the indications? When will you use it? The Sentinel stroke prevention devices and TAVI procedure.
So the data for stroke prevention, I'll address that question, is not clinical. It's mostly MRI infarct size. So devices are available. They're not widely used yet. They're not available in Pakistan. Bilal and Wasif, are you guys routinely using neuroprotection? So I'd like to get thoughts from Dr. Tahir Sagir. So we used to do these with the 3-cusp view. Now we're using the cusp overlap view for Evolute. What do you think about the valve position and the coaxiality right now?
I think the pigtail is little bit pushed, and in this cusp overlap, yeah. Okay, but the position is okay. I think now it's flaring up.
Sometimes if you pull the LV wire back, I find that it releases some of the tension and makes it a little bit more coaxial.
Yeah,
Okay, let's go. LAO, let's go LAO caudal, please. Okay.
And there's not a lot of parallax error. Remember, for those of
Just stop. Yeah.
those who do more sapien, with Evolute, there's a constant parallax issue where the front of the valve and the back of the valve. So you have to be very cognizant of that. Multiple views.
Right? Yeah, but we have to be hurry then.
Hurry then, yeah.
Okay, open it.
So,
And
yeah, pigtail boy. Pace 120.
open it, please. Open it. Yeah. And then we need a balloon here, please.
Yeah.
Yeah.
Keep forward pressure.
Yeah. Forward. Yeah.
It's very close to release now.
yeah.
Okay. Oh yeah. Okay. Let's remove this, please. Very carefully. First wire.
Pull the wire in the LV to release the tension. And
Yeah.
no cone, it's okay.
Nice. Okay.
All right, nice.
All
So
right.
the valve has been deployed.
Facing off. Let's have a sheath and balloon.
Ready. 14 French sheets ready. and
Omar,
the 26
Omar,
balloon
can I
ready.
ask you a question, Dr. Tahir? Dr. Omar Goktekin? As you know, there is low-risk patients and
So, get the
younger
sheet
age
first.
groups.
Let's get the sheet.
What
please.
things?
Go on 48 mag.
I can hold it.
Okay. Yeah.
Omar, can you hear me?
Not
Asad,
ready.
can you hear me?
Yes, we can hear you.
Pressure is
Asad,
not too close.
what
We have-
precautions will you be using to preserve the coronary,
That sheet.
especially
Take
for
it out.
future as the young patients, to
For
preserve the
future for-
coronary?
sorry,
What
say that again.
precautions you will be taking in this Evolute
So
or
we do, Mr.
implantation?
Alignment. So I'll tell you in a bit more detail once we
Yeah,
swap
just
the.
a second.
Just give us a 1
Time,
second. Yeah,
we like to do post-dilatation
Yeah.
first.
Just to add on to
the valve
the
is not-
Sentinel there for the question. So there's
The
two
valve
data
is
coming
heavily
out from
calcified.
US and UK soon from the Oxford, which will be the biggest study which will put an end to the Sentinel device. I've used it
26
a few
balloon.
times before. It's used to the right radial artery. It for very high risk, although there is no defined high risk patients for the stroke at the moment. But these two data, once they come out, the Oxford is almost complete their recruitment
on
at the
the heart.
moment, and the US is also, the Oxford is
27
around 10,000 patients. So as Usman mentioned as well, that there is no carotid protection evidence so far, but it has been used in some centers.
26 balloon, please.
So we see the pressures coming up nicely, diastolic's a bit low, rhythm seems to be
Yeah, was
unpaced.
Like-
Initial impression, there was
maybe-
a ton
Yeah,
of
yeah.
calcium. So,
have to
Ali,
leave it.
what do you think about,
high on
how do you
the
prep
non-side.
so much
I'll just
calcium?
keep
What are you
forward pressure
anticipating
on,
when you put in
Yeah.
a self-expanding
Our
valve with
aim
this
to-
degree of calcium?
Yeah.
So
that's
for
the-
a self-expandable valve, when I'm putting the calcium, I think on a few things, that whether I will have to
But-
post-dilate this valve or not. If I have to post-dilate, I don't aim too high for at times. Pre-dilatation is important. I tend to move away
Okay,
from the
phase 100,
post-dilatation.
200.
So I prep for the pre-dilatation of these patients for
Yeah,
that.
yeah,
As Dr. Taisagir mentioned, it's a bicuspid. So in bicuspids, I routinely pre-dilate always. In tricuspids, I don't routinely pre-dilate always in the calcified patients. So a few things probably from this. So as probably everyone knows that the preparation of the CT scan is very important. So I analyze all my CT scans myself to plan all those things.
So
Wire छोड़ें, wire
when
So
would
we
you
see that they're
consider-
doing
Yeah, they're doing post-dilatation.
post-dilation. Asad, what size balloon did you take for the post-dil?
So we are taking a 26, which is the mean diameter for that.
Negative, it's
Yeah.
more negative. And
So would you be
what's
dilating in everyone? What was the reason for post-dilating here?
No, this one, so we tried to do a 22 pre, but that balloon burst because of the heavy calcium. So here we don't think the outlet.
negative.
I know, but what's the indication for post-dilating?
Not now, no,
Like,
no, no.
Do you do it
No, no,
routinely
no,
in
no,
every
just-
patient, or are there any
Hold on,
particular
hold on.
reasons to do it?
If this is good, so we have to come back, yeah.
I think Asad is busy with that, but
Yeah, I think so.
Maybe
post-dil-
I can get comment from one of the.
Yeah, Doctor,
Bilal,
if there's a doctor-
when would you post-dilate?
The issue is that if you look at the annulus, it's extremely calcified, and annulus, it does not look as if it's completely and symmetrically expanded. So they do
200?
Facing 200?
to do it necessarily in every single patient, but I think in this patient,
Yeah, good, good. Go on, go on.
pre-dilatation is also something that is, look at how the valve,
No, 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 no,
Facing on?
no.
Okay, paste.
I think post-dilatation
Yeah,
in all
alright, so-
patients is not that necessary in a sense, but as Dr. Murad mentioned, that obviously this valve looked a bit constrained, so in this one you can do it. I would have probably lost a bit of a parallax from it because there is still some parallax in it, and this is a quite high valve as well.
So before post-dilating, generally I do assess, if we have TE, then TE assessment, or if invasive hemodynamics, I check a gradient if there's a residual gradient, or if there's significant AI. Because one, the data is not conclusive on the damage to the leaflets with post-dilation. There's probably some damage which we haven't quantified yet. And the second is, we always go for a higher implant to avoid putting in a pacemaker and reduce our pacemaker rates. And I have a theoretical concern about, embolizing the valve or causing some sort of issue. So Omer and Asad, are you guys happy with the valve position? What are your thoughts about? Where do you, Dr. Siddiqi, where do you usually like your valve? What's your depth goal for your cases?
Actually, we in cusp overlap view, we start with the middle of the pigtail and just a little bit down. And then after implantation, we regularly check in the LA view and an RA view and see for any parallax before we release the valve. And after we release the valve, we do aortogram to see for any paravalvular leak or any AR. And then afterwards we decide for any post dilation if the valve is not completely opened or any paravalvular leak.
In a case with this amount of calcification, there's always going to be some leak. So Asad, it looked like there were two jets, one paravalvular and one central that's probably wire associated. So I believe we have Dr. Usman online as well. And could I have you share your thoughts about the case and what do you think of the case so far? And with the PVL that's there right now, what would be your strategy? Asad, was it your intention to have the valve at zero, or do you think it was because of the pigtail and calcium? Bilal, what do you think at this point? What would be your strategy for the PVL? Leave it alone, do some further dilation?
I would leave it alone, the amount of calcification using TAVI. Sometimes, the enemy of good is better. And you have a really nice result over here. The valve has expanded a little bit. I think we should follow the other TE down the road. But I wouldn't expand this any further. Annular rupture is a catastrophic complication. Very nice result in a beautiful, in a very difficult case. I would accept this result.
Excuse me. So, Dr. Omer and Asad. Excellent. Yeah, I think with the and I think the degree of AS that the patient had, they're going to feel much better now that the AS has been relieved. And so a great result. Do you have any final comments before we switch over to our next mitral case?
So one short question, if you allow me, please. Here.
Go ahead with your question.
Yeah, so thank you very much. It was an excellent presentation and nicely case done by there. I want to ask two things. One patient, for example, has been, I'm quoting here, short stature female. Her aortic diameter, annulus diameter was 13 or 14 mm hardly, and she's been refused by the AVR. What kind of suggestion being just put up by you for this TAVI? Secondly, how much AR has been acceptable here post TAVI, and unfortunately if the TAVI procedure leads or drain to mild or moderate AR, what kind of rescues you are going to do in this case?
Ali, you want to take that question?
Yeah, so for because you should know that these self-expandable valves are nitinol valves, so they do expand over the period of the time. We had collected data in leads for this, and after the 1 month when you repeat the echo, if it's a mile, it is gone pretty much almost. Again, as mentioned by everyone, that you have to look at the benefits and the risks as well. If in this case, because as Asad did perfectly very well, and he left it in the end because there was a very big chunk of calcium there. Although it's a 0 millimeter depth, if you want to get rid of the PVL, you will have to post-dilate it more, and that can be in evolute is 1:100 pop-up rates with the post-dilatation if it's a very high 0 millimeter valve. So PVL for me, anything that is between mild to moderate, considering very high calcium, I leave it. And it does improve over the period of the next 3 months with the nitinol nature of it. Your first question, I couldn't get it very much.
This is a female, actually. She's having the Down syndrome, short stature, and her aortic annulus was 13 mm hardly, and she's been refused by surgery. So what kind of sedation here?
So, you remember? Sorry. Yeah.
We have to switch to another lab of the AFIC, where Sohail Aziz is doing a PTMC. Are we connected? Assalamu alaikum, Sohail Sahab. How are you? Yeah, we can hear you.
Bit about the case, slides for the case. This can bring Mohsin separately, and we got a wonderful team of assistant doctors Sajjad and Kamar, Basta, and Nasreen, and we've been Nadir with us here, and so a bit of a case before we show you what's going on.
Sohail Sahab? Okay. What's the age of the patient? Can you hear me, Sohail Sahab? A 40 years old lady. Would you be doing coronary angiogram for this patient or not?
We thought about it. She just 40, turned 40, so we thought that there's no need. She doesn't have any other comorbidity, so we chose not to do coronary angiogram. I'm not sure why the score was 6.
Because the valve was pretty pliable and it was 0.8, there was no MR. But she was quite breathless. So I wish we could show you some pictures also of the echocardiogram, because I think the safety of the procedure lies in the assessment before you go in. You got to make sure that the valve is right and it's pliable. And if there's calcification, you must make sure that it's not at 3 and 9 o'clock, because that's where the commissure splits. So if there's calcium there, you will tear not at the commissure but along the line of calcification of tissue and have an MR. I've done lots of densely calcified tail leaflets with PTMC, and as long as the 3 and 6, 9 o'clock angles are okay, things are fine. Actually, we're told that we're going to go offline at 9:45. So we waited till about 10 minutes ago, and then we decided that you were having such a healthy discussion on the TAVI, and of course, PTMC is like the poor man's intervention, so we didn't realize, we thought that you won't give us enough time, and because we got the lines in and we didn't give the patient any heparin, so in it
didn't take us long, it was about 6-7 minutes, but if you want, we can show you the steps we save on the floor, and so the procedure itself is just a routine, healthy activity, and whether you can see the whole screen right now?
Yeah, we can see the screen.
Yeah, okay. So the pigtail is in the non-coronary cusp, and if you bring it like TAVI in an AP view, it will land in the non-coronary cusp. And now we've got a 3-2 wire going up. Next, please. And on this Siddiqi for a moment. We've got a shield here to protect us from this the radiation, the whole team. Next week, and so next week decided to do the puncture. Now there are different ways of doing a puncture, and we reduced the blood and blood needle in there, and we just slide it down. That's every operator has his own particular way of doing it, and I won't argue what's better, what's not. It's just you're not following which catches it. It's the way you be trained. If you want the marker I use is the subcarinal angle. When you talk about X-ray, what are signs of enlarged left atrial microsis, splaying of the subcarinal angle. So subcarina is where we talk about the left atrium is. And so we just brought it down in AP, and we bring it on just below the mitral, the pigtail, which is marking the aorta. And because the sucker is bulging, it wasn't like stabilizing itself in a particular position where one could have punctured. It just kept on going back and forth. And by and large, you need to, some people go through the fossa, but that's not the best way to engage the mitral valve. You see, all these procedures where you have to do a septal puncture, be mitral plate or occlusion or whatever, PTMC, every procedure has different side of puncture. Like with the TAVI device, we have very low puncture, you go to LO90 to puncture, and that gives you a very good safe puncture, but it's very low puncture. So that puncture tends not to be very good for a noise technique. Anyway, so this is, we try to place it in that, just below that pigtail, and next piece. Then I tend to come in RO, and I make sure I'm not pointing posteriorly, and I'm just below and behind the pigtail, which is marking the aorta. I give us 2 inches or so from this screen, or in reality maybe in centimeters, and this would actually stick. As you can see, I couldn't find a stable position. Next please. So next please. So next what I did was I stuck the needle in there, and this is the puncture. So I stuck the needle. If the puncture, and the Balashi do not stabilize, I stick the needle up just a millimeter or so that it catches on something. If I'm happy, then I come back to the and I don't know, everything's got a stable position puncture, but in this way, if you can see that at that puncture, I do this injection, and you can see the super wall of the LM. That's where you visualize. I hope you can see that on the screen.
Yeah, we can.
And then after that, I push the mullins a little over the blood bodies so that it crosses septum. Sometimes what people do is that as soon as the puncture is stopped there, and when they push the UV wire, it tends not to go in. It just kind of you have to re-puncture it. So next please. Then we put out the part, and and then we took the basic position.
Sohail sab, can I interfere? Sohail sab, can I interfere? We in NICVD basically use the multiple views. That is, in AP view, we use the pigtail as a marker, and we see the superior and inferior landmarks for the puncture. And then we go into LO90, where we see the anterior and posterior boundaries. On that basis, we decide to go for the puncture. We 100% of the time we did this puncture in our mitral cases, but these puncture in AP view, these punctures are done by our EP colleagues routinely. So we have the opportunity of seeing their puncturing technique, and hopefully now we will try to learn that technique also. But routinely we do in a AP and lateral for superior, inferior, anterior, posterior landmarks.
The two lateral is what Alan Review also practice. What he does is he just pulls the puncture needle and the button bar just between the diaphragm and the pigtail, and then he points it towards the right, and then he goes through the lateral and makes sure that the
Okay. Sohail Sahab, can you wrap up the case because we have to have some talks.
Yes, okay.
What size of balloon you have used? What size of balloon?
She's 147, so we use a 26 balloon and stretch it 25. Next please.
Okay.
Okay, now we thought we crossed this, and then we went, we had difficulty in crossing, and you can see it looks pretty good. Then we had LO, next please. And we found, next please. Okay, they showed it. It was the puddle way. So we then reshaped the loopy wire and reshaped the position of the mitral, the alloy balloon. And next please. And this is the important thing to see that how we do it is we've got a picture there. We're going to inject into the picture as we place the alloy. Next please. This is something I want to take home with you. We inject hard, and so this is the whole LV outline, and you will see the mitral funnel, and you know exactly where you dilate it. I've risked inflation many times by inflating below the valve, damaging the mitral apparatus, and not yet breaking. And you think that you know approximately where you are, and you tend to be wrong sometimes.
Okay.
So this very nice technique to inflate the alloy in RAO with a picture running there. Just have to 20 cc, say, lower knob one, and inject very hard.
Okay.
And see, it's very satisfying to see it opening.
Okay.
And this is a very safe way of making sure that the position of the valve is right.
Okay, Sohail Sahab, thank you. It's very nice presentation and procedure by with such an experience. With the help of pigtail, you position the Inoue balloon, and with this help of pigtail, you can also see the track when you are manipulating the balloon into the LV, the J curve wire. If it's go outside the pigtail, that is it going into the LA appendage. So when you manipulate the Inoue balloon with the J wire, you have to have it in the medial side of the pigtail so that the balloon is always in the LV. Thank you very much. Hope. Yeah.
I'm showing you a picture injection in the LA procedure. You see the LA appendage very clearly.
Yeah.
So if you're not careful, you can puncture this and cause a catastrophe. The reason to take this picture was so that you could see where the danger lies in PTMC. And it can be disaster often it doesn't realize what it's done. So that's just the plan which was shown. Thank you very much.
But this injection is with the end hole. I think this hand injection with the end hole, I think it's safe to have a multi-hole catheter to be in the LA to push.
This is from the balloon.
This is just from the alloy balloon that I'm injecting. It's a hand injection. It's not very big, but at least I can see. I just want to show you where the LA is.
Okay, thank you. Thank you.
Tahir, can
Nice
I
case.
add a small point? I think in transeptal puncture is the main thing over here. And the way you do it in Karachi, we do the same thing in Peshawar as well. That we go all the way lateral, and we want to make sure that we have got our pigtail catheter as our landmark, and then we try to look back towards the spine. And that is perhaps the safest part of it, because you have seen and we have seen that when you're in the AP view or even in the RAO view, you can be grossly wrong.
Yeah.
And you may be going and hitting something else, and you probably will not be hitting the LA. So the safest perhaps for the people to learn will be to do it, the puncture in the lateral view or LAO 60 at the most if you cannot have your patient put his arms up, and that perhaps should be the message from this one. Thank you.
Ji, Saqib sir. And because in mitral stenosis patient, LA size is enlarged, the anatomy is deformed. This AP puncture is more suitable for our EP people.
And I think over and above the safety, it's also the ease of the procedure. If you have done the puncture right, you don't have to push the dilator so much. You go to the right part of the, near to the fossa vallis of the interosseous septum, and you dilate the interradial septum well, and similarly, the crossing the valve becomes much easier if the site of the puncture is well, and you don't have to loop around and things like that.
Okay.
So, and similarly, you don't end up so much near to the roof of the LA as was in this case. If the puncture is at bit lower site, then you stay. One of the very important precaution of PTMC is that while you are preparing the Innovative balloon, or when you're even coming out and stretching it out, you should stay away from the roof of the LA roof of the LA. And if your puncture is not appropriate, you're likely to go right through the roof of the LA after doing a procedure very well.
Okay, thank you. Now, next is a case presentation by Dr.
Right, thank you very much. It was a pleasure transmitting for you guys.
Thank you. Thank you, Sohail sir. Thank you, AFIC.
It's our pleasure. Thank you, sir. Great team.
Thank you, sir.
Dr. Abdul Salam is presenting a case of TAVI from subclavian approach.
अच्छा किया ना कर दिया पहले
बहुत अच्छा किया
है ना वरना तो